Welcome everyone. My name is Ben Adam. I'm a pathologist here at the University of Alberta. I just want to start off with our land acknowledgement for today. So the University of Alberta acknowledges that we are located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. And I would also like to say thanks to Paladin for their support of the ATI seminar series. And this is the first session of the 2022-2023 series for the ATI seminar. And we're happy to welcome everyone back with a list of excellent speakers and topics on donation and transplantation for this year. If you have any suggestions for speakers or topics, please send them to transplant@ualberta.ca. So today we have an exciting double header presentation, starting off with a summer student presentation by Ivy Fixsen, followed by a talk by visiting nephrologist from Poland, Marek Myslak. So I will just start off by introducing Ivy Fixsen. So Ivy, maybe while I'm chatting, if you could just pull up your slides, please.
Yeah, sure.
If you can share your screen, you should be able to. So Ivy is a fourth-year nursing student at the U of A. She's passionate about the biomedical field and understanding the human body. Working with the ATI this summer has been her first exposure to conducting research, and she says it has been a great learning experience, which is good to hear. She did receive the 2022 ATI Research Summer Studentship Award, and yeah, she'll be presenting a summary of her research for us today, with the title of her abstract being Molecular Characterization of Microvascular Inflammation in Early Post-Transplant Biopsies. So I'll hand it over to you, Ivy.
My name is Ivy Fixsen, and like Ben said, I was the summer student this year, and my project was focused on molecular characterization of microvascular inflammation in early post-transplant biopsies. So I thought I'd start with a case study to help illustrate the background of my project. So for the case study, we have a 66-year-old male who had a kidney transplant biopsy performed due to delayed function 10 days post-transplant. Some of his histological characteristics were severe microvascular inflammation, or MVI, and arterial inflammation, which was queried for active antibody-mediated rejection, or ABMR. For interest, his BAMP scores were glomerulitis with a score of 3, peritubular capillaritis with a score of 3, as well as arterial inflammation with a score of 3. So G3, PTC3, and V3. But interestingly, his DSA testing was negative for anti-human leukocyte antigen. So I've included a picture of his biopsy. So we can see here his glomerulus is quite filled with inflammatory cells, as well as over here we can see the arterial and the capillaries are very full of inflammatory cells, which indicate or suggest that this patient might be experiencing antibody-mediated rejection. So the official ABMR diagnostic criteria include MVI with the glomerulitis score greater than 0 and a peritubular capillaritis score greater than 0, which he met that criteria, as well as intimal or transmural arteriitis of greater than 0, which he also met that criteria, and at least moderate MVI. So the sum of his G score and his PT score are greater than or equal to 2, and his scores were higher than 2. However, there has to be serologic evidence of DSA or donor-specific antigens and C4D staining. However, this particular patient was DSA negative and had no signs of C4D staining, which creates a little bit of a problem or a question. So the absence of detectable DSA suggests that there's histological changes in the early transplant biopsy, may be indicative of severe ischemia and then tissue injury caused by sudden reperfusion injury rather than ABMR. And despite the classical association of these features with ABMR, this case highlights the potential non-specificity and difficult diagnosing it, particularly in the early post-transplant period. So as part of our project, we hypothesized that NanoString nCounter could be used to retroactively analyze kidney transplant biopsies to provide molecular characterization and further understand the phenomenon of DSA-negative ABMR in the early post-transplant period. For our methods, we used the NanoString human organ transplant panel, which includes 770 genes. And within that panel, we measured 6 literature-derived gene sets for specific diagnoses in 28 biopsies. So we used the genes identified in previous papers and research for this. We used 14 early post-transplant biopsies, post-transplantation day 3 to 10, with signs of microvascular inflammation. And then to compare those, we used 14 corresponding implant biopsies that did not exhibit signs of MVI. We use gene sets to measure transcripts that are classically associated with ABMR or antibody-mediated rejection, DSA or donor-specific antigen, endothelial injury or ENDAT, T-cell mediated injury or TCMR, early injury, and late injury. The ways that we quantified our data, we're using geometric means of the gene set scores, as well as students' t-test to determine statistical significance. So here's an overall summary of our findings. While there were some minor differences among all the biopsies and their corresponding implant biopsies, we found a statistical significant difference for biopsies exhibiting TCMR as well as late injury. So these ones had significantly higher counts than their implant counterparts. So for our ABMR gene sets, we used 34 different genes that are classically associated with ABMR, and which are right here for your interest. And we did not find a statistically significant difference between implant and MVI. And our p-value was higher than 0.05. Similarly, with our DSA-ST 20 gene sets, there were higher counts of genes associated with DSA-ST in the MVI samples, but it wasn't high. There wasn't enough of a difference for it to be statistically significant. For our endothelial injury gene sets, we used 31 different gene sets, and they were pretty similar, and there was no statistical difference. And with our TCMR gene sets, we used 61 different genes that are associated with TCMR, and we did find a statistically significant difference. There was significantly more genes corresponding with TCMR present in the MVI samples than the implant samples. And in the early injury kidney biopsies, we discovered no significant difference. It's relatively similar. And then these are the 59 gene sets that we used. And lastly, with late injury, we used 32 genes, and we did find a statistically significant difference. There was a higher count of those genes present in MVI more than implant. And we found this a little bit surprising because our kidney biopsies were all relatively new post-transplantation, between day 3 and day 10. And we did not expect to find so many genes that are associated with late injury and like scar tissue. And it would be fun to investigate this further. So for our conclusion, there were histological differences between MVI and implant. So histological differences between MVI and implant biopsies are not associated with changes in the gene expression patterns that were previously linked to ABMR, for example, DSA and endothelial injury. And TCMR and late injury differences, instead of reflecting ABMR, they may be indicative of nonspecific inflammation caused by the transplantation process, and parenchymal injury due to the ischemia and reperfusion. Some future ways that our findings could be applied in the coming future is we can, instead of using 6 literature-derived gene sets, we can try using the full 770 genes in the human organ transplant panel to create a new baseline and see if there are any genes that we missed. And we can also correlate the genes set scores with the histology scores, either using the kidney biopsies or the BAMF classification system. We can also compare or find a correlation between treatment and clinical outcome. So for those patients who may have had DSA-negative ABMR and were treated for ABMR, we can compare their clinical outcome with those who exhibited signs of ABMR but were not treated for ABMR, and see if there are differences in the clinical outcome to discover if those patients did in fact have ABMR. And we can also further investigate the cause of late injury genes in the early post-transplant biopsies and try and discover why they were present. Thank you.
Oh yeah, please.
This is a very nice piece of work. I congratulate you. It's a great way.
Thank you so much.
I hope you'll stay in research.
Yeah.
Listen, the 2 things about this patient. One, was the patient sensitized? Did the patient have high antibodies? Had the patient failed previous transplants?
No, yeah, Ivy wouldn't know the answer to this question. The patient was not sensitized. Okay. This particular
we have seen. So DSA is a measurement, and we have seen. We're working on a case report, a very highly sensitized patient who had a very severe early ABMR in 4 straight kidneys. as a tragic situation, a young person. We think that there are antibodies which can do this, which are not measured by the DSA test. And of course, this is quite possible because the DSA test has a limited number of targets. They could be non-HLA, or they could be HLA polymorphisms which aren't properly represented. At any rate, but the other thing is, and this is for Ben, I know centers which have done changes in the perfusion system and introduced a new system of perfusion preservation and caused microcirculation injury. And then they got a whole series of kidneys which they diagnosed as ABMR, which didn't have antibody. And in fact, very severe damage from a change in perfusion can actually produce a severe microcirculation injury. And I think this might be what's happening in this person. Do you know the details of the handling of the kidney?
So the particular case that Ivy presented, it was an extended criteria donor, and I can't remember the exact ischemic time, but it was quite a bit longer than what we would normally like to see. So there was definitely a risk for increased ischemic injury in this particular patient. Yeah, and they were not presensitized, but we did include, I think there were some biopsies in this cohort. We went back from like the last 15 or 20 years and tried to find all the examples that fit this profile. And there were at least one or two that were on like their second or third transplant and were presensitized. So in those cases, that could be a situation where we're just not able to identify antibodies that are present. Yeah. So it's probably a mixed.
Yeah, I'd be quite concerned that this is a kidney which had some, I think, as you say, an extended criteria donor, which might have gone through some stresses. But in particular, ischemic injury doesn't really produce this picture, but microcirculation changes due to the perfusion strategy. There was a time when we were using different perfusion strategies and we realized we're getting microcirculation injury. This is like 30 years ago. And I think there's something that's happened to the microcirculation here, I think. The fact that you do not have a signal for molecular ABMR tells me that something else is going on.
Yeah.
Anyway.
Thank you for the comments. Okay, if there are no other questions or comments for Ivy, thanks again, Ivy, for presenting your work, and I'll hand it over to you, Dr. Halloran, to introduce Marek.
Yeah, thanks so much for having me, everybody.
Thank you, Ivy. Everyone can hear me? It's our pleasure to welcome Marek Myslak. Dr. Myslak is an MD PhD from Szczecin in northwestern Poland, and one of the leaders in kidney transplantation in Poland generally. We've been fortunate to be collaborating with him now for the last several years. He received his MD and PhD in Szczecin, based at the Pomeranian Medical University, which is one of the leading universities in Poland. His PhD was also based on research work that he did in Germany. He has also had experience at the Mayo Clinic, and he's part of the team that introduced living donor program in Poland and is now working on desensitization protocols. He'll be talking to us about his experience with a very exciting initiative with Bob Montgomery and about trying to support the centers in Ukraine. And I thought this is a particular interest to us given our strong connections with the Ukraine. And he'll also talk a little bit about his molecular microscope studies. So Marek, we're really pleased to have you here, and thank you very much.
So I would like to share with you my experience from Ukraine, how they maintain the transplantation programs in the war zone. I also will briefly focus on the transplant monitoring and transplantation future. So this is how it all started. In March 22, Bob Montgomery, well-known transplant surgeon from New York, mailed me and asked if he could in some ways help Ukraine and if I could help me to achieve it. So without further hesitation, I decided to join him on transplant mission to Ukraine. We met in Krakow, Poland, and from there we transferred to the Polish-Ukraine border and then arrived into Lviv. The place was chosen because there was a still active transplant center despite the war. The hospital didn't look good from the outside, but from the inside it was completely modernized. We were warmly welcomed by the medical staff and the young head of the transplantation department, Maxim, whom you can see now on this picture. From the very beginning, we were asked for consultations of difficult patients and discussed future projects for that center. As surgeons wanted to operate with Bob, we started to do the transplant job immediately. As you may see on this screen, the war has impacted transplant activity in Ukraine, and several centers located in the eastern parts of the country ceased operations. Actually, only Lviv remained active after 24th of February. You may see the numbers of the transplants performed in 21 compared to 22, and there is substantial decline of those numbers, of course. So, operation unit was very modern, and two first kidneys were from dominant type of donation in Ukraine, which is the living donor. So first kidney was transplanted by Bob Montgomery, and Ukrainian colleagues have assisted him. So there are some pictures from the operation theater. The second transplant was performed by Maxim and his team, and Bob assisted them. As you may see here, part of those operations were broadcasted to the Ukrainian television. Everything went well, and the first American-Polish-Ukrainian transplant ended with success. The Lviv Center in 2022 have performed even more transplantations than they usually do, because many patients moved from the eastern Ukraine to the west because of the war. There is a very interesting story. If you look at the lung transplantations, there is only the one, and here is the Igor, the heart and lung transplant surgeon. So the short story of the lung transplantation is best quoted in his own words, which he sent me recently. 1 year ago, we performed with the help of the Polish transplant team the first lung transplantation in Ukraine. It was a historical moment for the medicine of Ukraine. Patient Victor, who you may see on this picture, was discharged from home and now feels very well, leads a normal life. When on February 24th, Russia attacked Ukraine, many transplant programs were suspended. Many of our citizens went to Europe. I sent lung transplant recipient to Zabrze, Poland. The clinic kindly accepted them. 1 month ago, a joint Ukrainian-Polish team performed a lung transplant in Poland for an Ukrainian woman. This is the first such case in the entire history of the existence of the two states. Patient Elena, which is shown on this picture, was discharged from the hospital in good condition 3 weeks after the operation. Igor, this is the letter from him to me. So we were discussing cases with our colleagues, and we tried to share some knowledge with them. We gave actually the 2 lectures, and now I would like to briefly to smuggle some main thoughts of our lectures. So this was my main topic, the transplant monitoring or post-transplant monitoring. These are the present kit. This is the present kit tool we have for this issue. But there are new molecular tools for the transplant monitoring. One of them is a gene expression examination, so the microarrays, and the second, cell-free DNA. And I would like to convince you on some examples how useful are those 2 methods for clinicians. Let's look at this first case from our centers when the patient was biopsied for cause, and this is there are the histological lesions with some PTCitis, but C4D negative. So we are not sure how should we treat these patients, but with the help of molecular microscope, where the yellow triangle shows the phenotype of our biopsy, we were sure that MMDX has conferred ABMR, so the patient received the proper treatment. In the second case, the biopsy has shown severe proliferative arteriopathy. As you may know, it could be quite unspecific. It can be related or unrelated to antibody-mediated rejection. And this time, MMDX supported decision of no treatment of ABM, as it shows relatively healthy kidney without ABMR or TCMR with mild inflammation, atrophy, fibrosis. Here is the third case with the histological picture, which you can see here. And there were some DSA present in this patient. And we have supported our clinical decision with MMDX result, which showed abnormal biopsy with moderate early stage ABMR. So molecular microscope and gene expression results supported clinical decision to treat this patient for ABMR. And now if you look for the usefulness of cell-free DNA from our perspective, we have the patient who had 2 biopsies at that time with negative DSAs, and those 2 biopsies showed IFTA ATN only. The yellow line shows you serum creatinine level, and the blue line shows you the donor-derived cell-free DNA, so derived from the transplanted organ. As you may see later, the patient was not biopsied until he became DSA positive. At that time, the biopsy has shown fully developed antibody-mediated rejection, which corresponds well to rising creatinine. But if we would monitor that patients with cell-free DNA all along the time, we probably could prevent delay in ABMR diagnosis between days 111 and 145, and the treatment could be delivered much earlier. There are now some slides shared with me from Bob Montgomery, and which shows that the number one unmet need in transplantation is organ shortage. So we should look for the new ways of unlimited sustainable organ delivery. One of them could be the production of bioartificial organs, for example, on the cellularized scaffolds of the animal lungs, or the direction which Bob develops now in his center as a pioneer, xenotransplantation from genetically modified pigs. I will not go into the details because of the lack of time. So this was the experiment which Bob has developed, so-called descendant model, where the diseased donor who became the recipient of the genetically modified kidney from the pig. And this type of experiments allows us to look for all the possible complications before we go forward to living humans. These are the pictures from the second transplantations, and there is a very interesting concept of so-called thymokidney. Thymokidney is the construction where the 2-month-old pygmy has transplanted his thymo tissue under capsularly into the later harvested kidney. This probably will promote immune tolerance in prospect recipients. So this is a very, very interesting and probably the future of improving tolerance for organs, especially xenotransplants. So now let's come back to the Ukraine and the war zone there. They have daily alarms which force them to hide in the shelters. Although in the place we visited, Lviv, is especially the Lviv center is where fortunately not bombed so far. They usually don't escape daily, and now they, even if I call them, they stay in their offices or operations theaters. There is a fuel shortage across the country. They have all the time a mobilization of the people to the army. There is a lot of international support for Ukraine, which you can see everywhere. There are checkpoints around the country, and a lot of soldiers looking for the minefields. But they estimate is very strong, and they believe they can win this war. So there is a lot of hope. This is the picture from one of the bridge I have found here in Edmonton. Maybe you have passed that bridge as well to the downtown. So there is a lot of hope despite the situation. They try to rebuild everything which was destroyed by the war. They try to rebuild the world's biggest plane, which was destroyed at the beginning of the war in Kiev. There is a lot of youth. We have met a lot of young staff working in that hospital, and there is a much work enthusiasm among them. There is a strong patient empowerment, as you may see on the corridors with the pictures of the patients who received organs in that transplantation unit. And there is a lot of international support in means of the medical equipment and know-hows and other means. So we are strong together. Hey, here you may see the logo of the American Transplantation Society and the Polish Transplant Society, and we try to support them since then. So I'm sure they have a chance really to win. We can win all together in this war between autocracy and democracy. And since our visit to Ukraine, I became an informal consultant in transplant nephrology, and Bob Montgomery has raised several $100,000s for the medical equipment there. And we are planning to go there again very soon. So that was all I wanted to share with you. Thank you for your patience. And if you want to help medically Ukraine, you may contact me on those addresses I provide here. Thank you very much.
Thank you very much, Marek. I think the question in our minds is that the Edmonton and central northern Alberta have been very richly helped over the years by the immigration from Ukraine. So there's a very strong Ukrainian community here and very strong sympathy with Ukraine and desire to help. So specifically, what can we do as individuals to help, but what can our university and our center do to help Ukrainian transplant programs?
So that's maybe is to share the somehow know-how with them and to support some grant programs for the fellowships in transplantation. They are very interested in this kind of help. Of course, some material help with medical equipment which could be shipped into the Ukraine. There is a large demand, especially in the eastern part of the country. And that's what I am doing now, and probably for us is easier because it's the same time zone to help them to consult some of the patients. My friend Agnieszka, transplant pathologist, will help them to build up their pathology, transplant pathology labs, which they lack of. So these are the ways we try to help them. And probably after our second visit now, into Ukraine will learn more after these months passed during the war. They plan to build a big rehabilitation center for war victims. And I know that Bob also tries to support them and make interest in among people who are responsible for orthopedics and trauma injuries as a way we can do.
Perhaps
I'll
introduce you to Lori West and maybe ask Lori a question. Lori, is there some way that ATI, perhaps through Marek, could make ourselves available as a center to help Ukrainian centers?
Thanks, Phil. I was just texting behind the scenes with several of the others, trying to think of ways that that the Alberta Transplant Institute could offer support. And maybe there are ways that we can certainly make our educational outputs available to any team members. You're very well, anyone is welcome to join the seminars, and we can make those available to you. I realize that's not probably the biggest thing that is needed, but at least as an educational outreach, that would certainly be something that we could offer, Marek. And then we could look at perhaps other ways of I mean, we have a huge abundance of transplant expertise here in Edmonton, and perhaps there are partnerships we could explore together.
Yes,
maybe we could just follow up on that. Why don't we just do that and make the ATI seminar series available to Ukrainian transplant centers?
Yeah, we can do
sure. This is good idea, because even despite the war, it raised morals when they feel as a part of the community, transplant community. Yes. So participating in meetings or seminar and having the access to it is very important for them. And somebody has asked about HLA testing there. This is a big problem really now in Ukraine. I know they asked me already sometimes for help for the patients, especially sensitized for HLA tests. So far I have invited patients to Poland, as they can get all medical service from the very beginning when they enter the country, and we test histocompatibility in Polish labs, because in Ukraine at the moment they have a very big crisis in this area.
Anne, do you want to comment on that? I think you had posed that question.
Yeah, thanks. Yeah, that was me who asked that question. I work in our histocompatibility lab here, and so I was curious. I think it is, I mean, it's a problem kind of everywhere, specific expertise and specific equipment. So, I mean, I don't know if interpretation or analysis is something that's easily done remote for support from anywhere. And maybe even some of our histocompatibility vendors could support, some of this too. I don't know if anyone has asked them to provide any reagents or anything in kind, but that might be possible. Anyway, just some thoughts. I don't know if what's already being done.
Maybe if I could just make an announcement too. Marek has mentioned Agnieszka, and Agnieszka, with a very long series of Polish last names, which I won't try to murder, is going to be giving a talk at 4 o'clock, and she's been cooperating with us and with Kim Selez, defining some new lesions in the kidney transplants with ABMR. And so that'll be a very interesting talk. So anyone who wants to join in that's in the 4 o'clock seminar series that we run, and contact me, and we'll be able to link you in to hear Agnieszka's talk. She's visiting from Warsaw.
Is there a link that you could post, Phil?
I don't know how to do that, Lori, but I'll get back to you.
Okay, sorry, I didn't mean to put you on the spot there. Maybe Patricia, you've posted something about how, and of course it's not just our Ukrainian colleagues, but our Polish colleagues may be interested as well. But do you want to just comment on how they could access the educational seminars?
Absolutely. So our seminars are open to the public, open to everyone who wants to join, and the schedule is published on our website. I put the link for that in the chat. And then if time zone is an issue, then folks can catch up with the recordings that are posted on our YouTube channel every week. I think the key would be just communicating that information to those who would be interested, and perhaps Marek, you would make a logical sort of communication link to colleagues who might be interested.
Now, Marek, you mentioned that we might be able to help by medical equipment. There are times when we have medical equipment which is redundant to needs here. I know this is not an easy thing to do in terms of liability and that kind of thing, but are there any pieces of equipment in particular which could help the Ukrainians during this?
Yes, I know the perfusion, kidney perfusion machines would be very helpful, because now they have restrictions with the organ transplants, so the ischemia time is much longer from deceased donors during the war. So they would really need some perfusion, kidney perfusions machine for sure.
Was that from you, Andre? Did that answer your comments that you contributed?
Oh, yeah. Oh, sorry. And thanks for answering, Marek.
Yeah.
I'm Andre. I'm Brazilian. I live in Edmonton. But I know that how it can help, because the experience that I had in Brazil for so big country, and if we can take these organs, I can imagine how the transportation is too hard for you guys now, and probably to help more and to take more organs and to take out these patients from hemodialysis, because probably they are having a big issue about the water and the country. I can imagine about that, about energy, about everything. So you have to do transplant as soon as possible for them. So it could be I think a good thing to help them. And other thing about, like I said now, how are the patients on hemodialysis in Ukraine? How are they dealing that? Are you taking all them to peritoneal dialysis or something like that? Because how can you see about that?
Yes, sure. This is the problem. Many of those patients flew to Poland. As you know, Poland has admitted more than 2 million of Ukrainians, and among many patients who are on the dialysis, so many of them are put on the hemodialysis in Poland nowadays. And even in my place, in my ward, I have now one Ukrainian nephrologist from the dialysis unit in Zaporozhye and a nurse from there. And I know from them that their patients were transferred to the Western Ukraine, but still some dialysis units operate even under the war and bombing. So is a tough time for them. And so sometimes even these transplantations in Lviv is a kind of rescue therapy, if you can take a faster track toward the transplantation. That's for sure.
And is there access to immunosuppressive medications for them?
Yes, they have, and it even amazed me that they still have enough immunosuppressive drugs, and then they treat the patients very modern with the same immunosuppression protocols as we do in Western parts of the world.
And could you comment as well on the non-renal population? You mentioned the lung transplant patient, but are there transplants in the heart and in pediatrics as well?
So I'm not. I don't have much knowledge about the pediatrics. So they still transplant in those centers who are active, like Lviv. They transplant hearts. And the lung transplantation is mainly supported by the Polish centers. As I showed you on the picture, the first lung transplant was performed in Lviv as a joint venture with Poland, and now was the second, so only second. So the lung transplantation is still very undeveloped in that country. Maybe one of the reasons is that they have very few deceased donors, and especially now during the war, nobody cares to recognize brain dead persons because of the war casualties. Yeah? So So it's everything. I think when the war hopefully is over, there will be a time to rebuild all the system, and then a lot of help will be needed.
Well, I'd really like to thank you, and I hope that on our behalf you extend the best wishes of the Alberta Transplant Institute and the University of Alberta to our colleagues there, and our desire to support them.
Yes,
Thank
I would
you.
echo that. Thank you, Phil. I would just echo that and say, you know, from both the Alberta perspective and possibly also the national perspective through our national program, there may be opportunities that we could work together to offer some kinds of assistance that would be useful to you.
Yeah, we are staying in touch here with the Alberta Genomic Center and with Phil, so we'll share ideas very soon.
Anne has a question about laboratory equipment.
Yes, for sure they need it as well. Of course I will ask them for specific needs, so I will know more from this perspective as well.
Yeah, I know we sometimes send things to surplus because they are not needed locally, but they're still functional. And so I'm just wondering if there's some way to, rather than send them to surplus, just, you know, that seems silly when other people can use them. I don't know exactly what happens when they go to surplus. I don't really know what that even means, but maybe I can intervene before that black box of surplus happens.
Maybe there's a whole bunch of stuff in surplus.
Honestly, there could be. I think it's a good question. I'll have to ask my manager what surplus actually means.
Well, thank you very much, and thank you, Phil, for bringing this to our attention, and thank you for presenting Marek to our group. And we look forward to staying in touch and expanding perhaps some potentially helpful partnerships. I could just see that Saida has just posted in the chat next week. Andre will be presenting, Andre wave there, on challenges of deceased kidney donation in Brazil. So we look forward to continuing our series next week. Thank you everyone for the participation, and Ivy as well for presenting her summer student findings.